Wendy Berg from Children's Hospitals and Clinics of Minnesota, and then Christine McMullen and Dr. William Green from Stony Brook University Medical Center will present their success stories. And now I turn things over to you, Wendy.
Thank you, Ronnie, and thank you for having me. Next slide. Children's Hospitals and Clinics of Minnesota is a two-hospital system. We have 106 intensive care beds for newborns located on two campuses in St. Paul and Minneapolis, Minnesota. In the early 2000s, roughly 1 in 4 of our very low birth weight infants acquired a hospital-associated infection at some point during their stay. And with those kind of odds, infections really were seen as inevitable and just part of life in the NICU. Next slide. So in order to address these high infection rates, we took some action. We formed multidisciplinary infection prevention teams, which was a little bit of a change from our more broadly focused quality improvement teams of the past. And we had to do some work to address our culture change. We just needed everyone to believe and to buy into the idea that infections were actually preventable. So we accomplished this in a number of ways, starting with the nurses at the bedside, and we provided them all with 4 hours of infection prevention education. And then our infection prevention team started doing focused event reviews on each and every infection. And the result of each focused event review included a patient impact vignette, which was published in the unit newsletter. It included this little sad-looking baby that said, "It's more than an infection to me," and the vignettes outlined the patient's status before, during, and after the infection and really revealed the stories behind the numbers on the graph. Well, like many hospitals, we implemented the insertion and maintenance bundle, including the use of chlorhexidine, and audited, and we continue to audit for compliance with that. And then in order to keep staff invested, we needed to share our progress regularly. We posted days since last CLABSI along with rate graphs publicly, which added a new level of transparency and a sense of accountability among staff. And all along the way, we were mindful of message fatigue. We can't just present the same graphs in the same way month after month and expect people to still be interested. Next slide, please. So as a result of all of this work, we saw some nice decreases. This is a graph of our central line bloodstream infections and have sustained quite a bit of a lower level over the past 4 years. And next slide. But beyond just CLABSIs, we've seen a reduction in all bacteremias and other infections as well. This graph depicts the Vermont-Oxford Network's definition of nosocomial infection, which includes all bacteremias and meningitis. And by this definition, and this is just for our very low birth weight infants, by this definition we've gone from 1 in 4 infections to fewer than 1 in 10 in 08 and 09, and the 2010 numbers are not in yet, but they are looking promising as well. Next slide. So as a result of all this hard work, if we compare our 2005 rates to our 2009 rates, we estimate that we're preventing 64 hospital-associated infections each year. That would, if we multiply the $13,000 per infection in an NICU, that's a total estimated treatment cost savings of $864,000 per year. Previous work has estimated that it costs about $116,000 a year to participate in quality improvement activities because it does take time away from the bedside and work to implement all these improved practices. But if you subtract that out, it's still a net savings of about $750,000 in estimated treatment costs saved. We also know that very low birth weight infants are more likely to develop cerebral palsy than those who have had infections than those who have not had infections. And we estimate that by preventing these nosocomial infections, we are also preventing 5 cases of cerebral palsy and the long-term challenges that go along with it each year. Next slide. So what have we done that has caused us to be able to sustain these over the past 4 years? One main key is collaborating between the 2 NICUs within our facility and also collaborating with the broader neonatal community through the Vermont-Oxford Network. We, of course, have engaged multiple disciplines. Everybody has a piece to this puzzle, and we've also been very successful in engaging our family advisory board so that everybody works on their pieces to the puzzle. As I mentioned, we make frequent tweaks to our communication processes and are constantly soliciting feedback from staff of, do these graphs mean anything to you? What would be meaningful to you? How can we present this in different ways? And really trying to change up our communication techniques frequently just to capture people's attention and sustain that. And one of the really big steps forward, I think, was when we married up the patient impact vignettes with the data in the graphs. So in the context of educating our staff about what each of us can do to prevent infections, the vignettes really connected the individual staff person's actions with patient outcomes. And then lastly, and very importantly, we have enjoyed continued strong support from all levels of leadership within our hospital, and they've made reducing hospital-associated infections an organizational goal and have clearly defined the measures so that we know if we are meeting the goal, and have offered resources needed to work towards these goals.